what we worked on, this was work for the past couple of years using the PETAL Consortium global data set. But the problem we tried to answer is that in T-cell lymphoma, there are not a lot of options there's not a lot of options in general. But after you've progressed on frontline treatment, there's really a handful of therapies available that we would use. And because the disease is so aggressive and people relapse or they just don't respond at all, a lot of the time, what you end up having is all these people with maybe differences in their disease, maybe different histologies, different risk scores, etc. But they end up getting the same treatment. And the only difference between them, other than maybe their histologies, is the order in which they receive the treatments. So the question we tried to answer is, well, does that order matter if they're all going to receive the same treatment? Is there a way we can optimize the way that we give it, and maybe better use the tools we have? So it's kind of a tricky question because if you think about an interventional trial or a study, you're assessing the effect of one thing. You try to make sure that the two groups are as equal as possible, and then you give them one treatment and you compare and you see any effects attributed, or any effects that happen you attribute to then the treatment that you gave. This study was a multi-intervention study, quote unquote multi-intervention, where it's an observational study using the data set, the PETAL Consortium global data set, but it's designed as if it was a prospective interventional trial with more than one intervention. And the interventions we looked at were, okay, you have maybe three buckets or four buckets of treatment that you can receive in the second line, and then you can receive any one of those treatments or the same treatment again in the third line, or you could choose no more therapy in third line. So you end up basically having 12 potential combinations of treatment across 2 lines of therapy. And that's kind of how we modeled the question. And what we found is in the second line therapy, both epigenetic modifiers, which is a class of medications, and small molecule inhibitors, which are another class, did better than chemotherapy. And we had a fourth arm there that looked at brentuximab, an antibody drug conjugate drug, and everything did better than chemo in the second line. When looking at sequential therapy over 2 lines, so second and third line combined, we found that using small molecule inhibitors in the second line and then followed by epigenetic modifiers in the third line had the best survival. Although with the limitations that we're using a retrospective data set and is a very complicated clinical question to model. Yeah, it was pretty exciting to see, and I think it's in line with a lot of the other data that's coming out with the PETAL Consortium, but also other data from other investigators worldwide, where we're seeing small molecule inhibitors, epigenetic modifiers are improving survival, especially in certain histologies or certain risk groups, which is consistent with what we found. So it overall kind of supports the messaging that we should be putting chemo away for these patients, and chemo is not really effective that much in this disease state anymore. And it also, by looking at sequential therapy and seeing that survival benefit that we found in the second line therapy, the second line setting, it really supports the earlier use of these targeted therapies. So a historical practice, while there is no universally agreed on practice, some people will give chemo maybe 1 or 2 times, maybe even 3 times to see, okay, what about this regimen? What about this regimen? Maybe I'll get a response. And then they start reaching for these targeted therapies or epigenetic modifiers in the third line, fourth line, beyond. But what we're finding is that even as early as second line, we're seeing a really pronounced benefit over chemotherapy. So I think that's the big implication here, is that we should be moving away from chemotherapy earlier on, as soon as even the second line. There's a lot of cool things. So this was the first, or the retrospective data set was the first initiative of the PETAL Consortium. And with this retrospective data set, it's one of the world's largest data sets in T-cell lymphoma and the largest for relapse refractory patients. We were able to answer a lot of these important questions. So we were able to create a risk score, like the PERT score. Now we were able to answer the question of sequence and other targeted therapies in relapse refractory settings. but we're always kind of limited to a certain degree by certain biases that are implicit in collecting data retrospectively. Um, while we do a few different things like many stability analyses, many of our results are consistent with other trials. Um, we feel like we've probably minimized the bias to a good degree, but that bias is still implicit. And on top of that, now in the modern age, we have things like whole exome sequencing, next generation sequencing. We have a better understanding of the genomics and the molecular landscape of these diagnoses. So the next question is, okay, we looked at the drugs. Now we have to look at the disease a little bit better and see, are there differences in, a PTCL not otherwise specified? Are those patients who are, quote unquote, not otherwise specified really making up many other subtypes that we just haven't classified yet? And if so, are those mutations or molecular markers, are they prognostic? Are they linked to a certain response? Do we have to modify therapy? Do we have to develop new therapies? So a lot of these questions are coming down the pipeline with the second initiative of the PETAL Consortium, which is the prospective portion. So all of our PETAL sites that were included in the retrospective portion are included in the prospective portion, where we're prospectively actively enrolling patients with new diagnoses. Plus, we have some extra additional sites across the world. But we're now correlating their genomics, which now we're able to test in the modern age, their genomics with their clinical outcomes, like survival, like treatment response, with the treatments they received, with their risk of even having a toxicity on these therapies. And uh, a really cool thing that we're also looking at is quality of life measures, which hasn't really been looked at in T-cell lymphoma at all. But that's a big factor in how someone decides treatment, or their quality of life is a big thing that would help drive decisions for treatments or other things like that.